At the beginning, I would like to ask you to keep a piece of paper and a pen ready. Because I'm going to start with some questions just to keep your attention on the presentation, right? Then we'll also talk about a bit about foreign training in UK with relevant to this UTIs, right? And we'll try to answer some questions at the end. So, to highlight the importance of UTIs, so I'm going to start with the case history. So, this child, I have seen some years back when I was a registrar at Kaluboilo Hospital, and this child was seen at 1 year of age at the cardiology clinic for a follow-up 2D echo. So, hope you all can hear me properly. Um, at that time, so this child was seen at the cardiology clinic at LRH. So they are, before doing the echo, they routinely check the blood pressure of the child, and so as usual they check the blood pressure of this child at 1 year of age at the cardiology clinic, and they found that it was quite high. So as a result, they referred the child to the pediatric team for further investigations. So then we investigated this child, and by that time child had established chronic renal failure. So when we look back into the past history, this as a neonate, this baby was ventilated and treated for sepsis, and also had undergone echo at that time, which showed left ventricular hypertrophy. So that's why he came for a follow-up echo at 1 year of age. So this child, we found out that the child had hypertension at 1 year. So there was a delay and a management issue actually. No one has checked the blood pressure until 1 year of age. So by that time, this unfortunate child had developed chronic renal failure. So we can assume this child probably had urinary sepsis at the neonatal period. As a complication, got hypertension, and which was not controlled properly. As a result, child developed chronic renal failure. So this child, unfortunate child, I have seen again when I was a senior registrar at LRH couple of years later, but unfortunately this child died there at ICU at LRH due to complications of chronic renal failure. So I hope that will highlight to the importance of identifying UTIs and managing them properly, and importance of arranging the necessary investigation. So as I mentioned before, so we will start with some questions and try get a piece of paper, and in couple of minutes try to write answers to these questions. And if you want, you can type the answers in the chat box. So I will mention the answers actually as I progress in my presentation. First question is, what is the commonest organism causing UTIs? And second question, what is the significant growth in urine culture? How do UTI present in children and neonates? What is bowel and bladder dysfunction? How do you examine a child with possible UTI? How do you investigate and treat UTI? And what will happen if you don't treat them properly? Okay. So we'll try to answer the questions one by one. So first question is, what is the commonest organism causing UTIs? So as you know, E. coli is the most common organism causing UTI, and it accounts for up to 80% of cases, 80 to 85%. And another question with that, like if you if you get a chance, like you are going to get a UTI, and if you get a chance to select the organism. Say you can get the E. coli organism or a non-E. coli organism. So which one do you prefer, E. coli or non-E. coli? Right. So studies have shown that non-E. coli organisms are more likely to cause renal scarring. Right. So in that sense, E. coli would be better. It would be better to have a UTI with E. coli. And what is a significant growth in urine culture? Uh, as you know, we take the cutoff for a significant growth as 10 to power 5, more than 10 to power 5. So why 10 to power 5? Why not 10 to power 7 or 10 to power 9? So actually, this 10 to power 5 figure was taken by decided by a person called Cass, who lived some time back in 1959. Just for the lab convenience, he took the cutoff as uh, 10 to power 5. So it was not based on any research, right? Just for the laboratory convenience, he took 10 to power 5 as the cutoff. So later on, they did studies and found out that in a true urine culture, there will be around 10 to power 7 to 10 to power 9 in a true UTI. So when you consider this, so about 50% of positive cultures we take as positive cultures with a growth of more than 10 to power 5 will be contaminations, right? So in other words, so if you get a culture report as 10 more than 10 to power 5 from the lab, it could mean either just a contamination or it would be a true UTI with the growth of 10 to power 7 to 10 to power 9, right? Okay. So how do UTI present in children and neonates? So I hope you all know how they present. So in bigger kids, they can come with urinary symptoms, or sometimes they can come with episodes of unexplained fever without any focus, or they can come with tummy pain, renal angle tenderness, and so on. Neonates are different, so they come in different ways. So they can also come as fever, episodes of fever. Uh, Again, they can also present with uh, failure to thrive during neonatal period as infants. So any child who is not gaining weight, we have to check the urine culture, and also they can present with jaundice, right? Obstructive jaundice, right? Conjugated jaundice, right? Again, then next question is, what is bowel and bladder dysfunction? So some of you may have heard about these terms. So what does it mean? So I'm going to discuss further in my presentation. So for example, uh, children who are constipated, they are more likely to have UTIs, and other behavioral problems, like for example, children when they are at school, they are reluctant to go to these common toilets. So as a result, what they do is they drink less water and withhold urine, right? So this can give rise to urinary tract infections. And how do you examine a child with possible UTI? So we'll discuss it later. And how do you investigate and treat a UTI? So investigations in our setting, we do ultrasound scan and then MCUG and DMSA. So there's a difference between management in UK and our country, because in UK, all the mothers, pregnant mothers, antenatally they undergo a CR scan to look for renal problems in the fetus. But in our setting, not all the mothers undergo these sort of a CR scan. So in if you look at these nice guidelines, they like they don't usually recommend routine ultrasound scan KUB following a UTI. But in our setting, any child uh, who's having a UTI, culture positive UTI, should undergo a ultrasound scan abdomen. All the children, right? So then how to treat, we'll discuss that later. And what will happen if we don't treat the UTI properly? So it can, so I discuss the case history of a child I have seen some time back. So they can develop hypertension, complications, hypertension, proteinuria, or even end-stage renal disease, renal failure. Right. So, so if you have any questions, you can type them in the chat box, and at the end, we'll try to answer few of those questions. Okay. So this is the overview of my lecture today. So I'm going to discuss about epidemiology and risk factors, clinical features and diagnosis, UTIs in neonates, acute infectious cystitis, and acute management, imaging and prognosis, and long-term management and prevention. So epidemiology and risk factors. So as I mentioned earlier, UTI is a very common and also very important clinical problem in childhood. So UTIs, basically you can divide them as upper tract UTI and lower tract UTI. So upper tract in the sense that is pyelonephritis, and which is the most severe variety, and which can give rise to complications like renal scarring, hypertension, and end-stage kidney disease. Lower tract UTIs are usually benign and include cystitis, viral cystitis or hemorrhagic cystitis. And but on clinical grounds, the differentiating the two will be difficult, especially in young children. And this whether they have fever or not should not decide, uh, should not, when we plan for investigation, we don't take the fact whether this child had fever or not. Right. Epidemiology. So prevalence. So we have to have some idea about the prevalence of UTI in various subgroups, and also about the risk factors for UTI and risk factors for scarring, and this will be helpful in managing these children and when planning testing. So overall prevalence of UTI is approximately 7% in febrile infants and young children, and it is affected by various factors like age, race, ethnicity, sex, and circumcision status in male babies. And prevalence is highest among uncircumcised boys, particularly those who are younger than 3 months. And white children, they have a higher prevalence, 2 to 4-fold higher prevalence compared to black children. And girls have 2 to 4-fold higher prevalence compared to circumcised boys. And white girls with temperature, high temperature, have a prevalence of 16%. So microbiology. So as I mentioned earlier, so E. coli is the most common bacterial cause of UTI, and it accounts for approximately around 80 to 85% of UTIs in children. And it can be also, like UTIs can be also caused by other gram-negative bacterial pathogens like Klebsiella, Proteus, Enterobacter, and Citrobacter. And sometimes gram-positive bacterial pathogens can also cause UTIs, for example, Staphylococcus, Enterococcus, and rarely Staph aureus, like for example in preterm babies. So this picture shows E. coli organism. So as I mentioned earlier, so infection caused by other organisms other than E. coli is associated with a higher likelihood of renal scarring. Inflammatory response also differs with the pathogen. So some organisms have various virulent factors, and viruses and fungi can also cause UTI, but they are uncommon. So I have listed the viruses and fungi there. And viral UTI are usually limited to the lower urinary tract, that is viral cystitis. You may have seen these sort of children in your day-to-day practice. So these children come with the they come with red colored urine. This will last only for a few hours, right? So in the morning the child will have the red colored urine. By afternoon it will clear up. But we have to investigate, like we have to investigate this child to narrow down our diagnosis. When a child comes, as you know, when a child comes with a blood stained urine or hematuria, we have to differentiate whether it is coming from, can be a problem in the bloodstream like DIC or low platelet count, or it can be a problem in the kidney, for example, renal tumor or renal calculi, or it can be a problem in the ureter, it can be a growth in the ureter or calculi, or it can be due to cystitis, problem in the urinary bladder, or even it can be due to a problem in the urethra, right? So as you know, we can do some investigations to differentiate uh, or to find out the origin of these red cells. For example, if it is coming from higher up, from the glomerular level, you will see casts, red cell casts in the UFR, and then you can also see dysmorphic red cells. Right? So what are the risk factors for fungal UTI? Children who are immunosuppressed, or children who are on long-term antibiotics, or on long-term like indwelling catheters can develop fungal UTIs. So pathogenesis. Uh, where does these organisms come from and cause UTI? So most of these organisms originate in the from the bowel, but rarely. So this is ascending organisms. They ascend from the bowel, right? But in neonates, there can be a hematogenous spread. So the first step of developing a UTI is first these organisms will colonize in the periurethral area, then they will ascend to the kidneys and mount an inflammatory response there. As I mentioned earlier, so certain organisms have virulence factors. For example, E. coli have this pili, and which will help them to ascend. Like even without a VUR, circulatory reflux, they can ascend into the kidney and mount a intense inflammatory response, which can eventually lead to renal scarring and other complications. So what are the host factors? Age. So the prevalence of UTI is highest in boys younger than 1 year and girls younger than 4 years. And lack of circumcision. So uncircumcised male infants with fever have a higher prevalence, 4 to 8 fold higher prevalence compared to circumcised males. Again, uh, not like so to prevent, studies have shown that to prevent a UTI, if you are going to do circumcision, you have to do circumcision in 111 children to prevent one UTI. So it is not recommended in the aim of preventing UTIs. I mean circumcision. Right? So female infants have 2 to 4-fold higher prevalence of UTI than male infants. So we commonly think it's due to the shorter female urethra, but there are other factors, contributory factors also. That's why neonates, like incidence in neonates is very high, maybe more than in young girls, right? So short urethra itself is not the only reason for them to develop higher incidence. Race and ethnicity. So white children have higher prevalence compared to black children. So genetic factors. What are the genetic factors? So first degree relatives of children with UTI are more likely to have UTI than individuals without such history. So I hope you know that this vesiculated reflux can also be familial. So if there's a one affected child in a family, so if this child is coming to your clinic, you have to screen the other children in the family to see whether they are also having a vesiculated reflux. So this may be correlating with this finding, right? So sometimes this bacterial adherence may also be genetically determined. So urinary obstruction. Children with obstructive urologic abnormalities, they are in increased risk of developing UTIs. Why? Because this stagnant urine is a good culture medium for these pathogens. So what are these predisposing obstructive abnormalities? They include anatomic conditions like PU valves and other uretropelvic junction obstruction. So posterior urethral valve is very important to exclude in a male infant, right? So all babies, all male babies, you have to ask about the urinary stream from the mother. So if they don't have a good urine stream, then you have to investigate them in view of excluding a PU valve, right? So otherwise they will develop circulatory reflux and then even renal failure, right? So then other neurogenic conditions can also predispose to UTI. For example, meningomyelocele with neurogenic bladder, and functional conditions we'll discuss later, like bladder and bowel dysfunction. Right. So what is meant by bladder and bowel dysfunction? So this is an abnormal elimination pattern. So it can be frequent or infrequent voids, or for example, it can be daytime wetting, urgency, or infrequent stools. Right. So as I mentioned, some of these children have this withholding maneuvers, right? Like for example, in schools, as I mentioned earlier. So the pathophysiology behind this is varied, but it includes abnormality of function of the muscles of the pelvis, bladder, and sphincters. So most of the time it's a bit of overlooked factor in the pathophysiology of UTI in children. And it is blood and bowel dysfunction is a risk factor for persistent VUR, renal scarring, and also recurrent UTIs. So what is VUR? So it is the retrograde passage of urine from the bladder into the upper urinary tract, and it is the commonest urologic anomaly in children. And these children are at increased risk of recurrent UTIs. And in young girls, sexual activity can also predispose to UTIs. So So this is a VUR grading. So lower grades like grade 1, 2 and 3, usually you don't have to do anything, but higher grades, grade 4, 5, you might have to get surgical opinion. Sometimes they may need um, ureteric reimplantation. But studies have shown even this higher grade VUR can resolve with time. So with bladder catheterization, there's an increased incidence of UTIs. So, so if you catheterize a child for any reason, you have to make sure you get rid of that catheter as early as possible. So, what are the risk factors for renal scarring? So, renal scarring is the loss of parenchyma between the calyces and the renal capsule, and it's a complication of UTI. So, as I mentioned earlier, long-term consequences of renal scarring include hypertension, decreased renal function, proteinuria, and chronic renal failure. So, diagram there shows a TMSA scan, and arrows are the scarred areas. So, what are the general risk factors for scarring? So, recurrent febrile UTIs, and then delay in treatment of acute infection. So, if there's a delay, so for example, if a child comes with recurrent unexplained episodes of fever, and then you didn't catch this UTI early, and if there's a delay in starting treatment, it can lead to renal scarring and bladder and bowel dysfunction again, and other obstructive abnormalities and VUR all can lead to renal scarring. So, prediction of renal scarring after first UTI. So, studies have shown renal scarring up to 15.5% of children following the first UTI. So, the predictors are the VUR, higher, especially higher grade VUR, and abnormal renal bladder ultrasonography, and elevated inflammatory markers, and neutrophil counts, and high temperature, and as I mentioned earlier, UTI caused by organisms other than E. coli. So, what are the clinical features and diagnosis? So definition of UTI is the bacteria, significant bacteria in a clinically of a clinically relevant pathogen, and plus there should be pyuria, right? So organisms plus pus cells should be there in urine. So fever may be the only sign in infants and young children, and older children will have other symptoms as we discussed earlier. So history and examination is quite important. In the examination, you have to measure the temperature, check the blood pressure, and growth parameters. So this recurrent UTIs can give rise to like failure to thrive. Sometimes they may be having chronic renal failure, which can impair their growth. And then abdominal examination to look for tenderness and masses, and there can be renal angle tenderness, and both male and female babies, you have to check the genitalia. It's very important to check the genitalia. In boys, they can they can have non-retractable prepuce. Sometimes when the prepuce is non-retractable, so usually, as you know, like if you don't do the circumcision, some babies you can't retract the prepuce fully. So usually these children will recover by around 8 to 10 years of age. But when you but afterwards, if you can't retract it, you can do a surgical correction. You have to get rid of that extra prepuce, And this non-retractable prepuce, other problem is like under this foreskin, organisms can harbor, right? So the cells which are shedded will accumulate there, and organisms will be there, and so as a result you can get a like a positive culture even. So this is not a true UTI, but these organisms can harbor there. And females also, you have to check the genitalia. Female babies, they can have labial adhesions. Hmm? And you have to check for signs of occult meningomyelocele, and you have to look for other focuses of fever. So what are the urine tests we can do? So we can do urine dipstick. In our setting, we don't do urine dipstick testing commonly, but in while we were in UK, we did that. In our setting, most of the time we do urinary microscopy and culture. So how do you take this urine sample for culture? So if it's not a toilet trained baby, then we have to either do catheterization or suprapubic aspiration. And if it's a toilet trained child, then you can get a clean voided specimen or midstream urine for culture. And we do not recommend sterile bags to collect uh, urine for culture. So when we were doing like during the foreign training period, they used various other things like in there were urine pads. Like you can keep in young children, you can keep this urine pad under the pamper, and you have to regularly check whether the child has passed urine. But in half an hour, if it is not wet, you have to remove it and put another urine pad. And once this child passes urine, you can squeeze that urine from that pad using a syringe and a plunger. Right? So those are not the ideal way to take a urine culture. Sometimes some take like washed up potties, you can collect urine samples, but the recommended one is for toilet trained babies, it will be midstream urine sample, but children who are not toilet trained, best thing is to go for a catheterization or suprapubic aspiration. So to diagnose UTI, as I mentioned before, you have to confirm by culture report, and there should be significant bacteriuria. And so as I discussed this earlier, so in our labs we take more than 10 to power 5 as a positive culture. That is a clean catch urine sample. But in a catheterized sample, we take half of that as positive. And if it is a suprapubic aspiration, any amount of organism we take as positive. Or in other words, like more than 1,000 colony forming units. So pyuria, you can check with the urine dipstick, or you can use microscopy. So sometimes some children can have asymptomatic bacteriuria also, and there can be other reasons to have pus cells in urine. For example, I have listed there occult pneumonia, group A streptococcal infection, appendicitis, Kawasaki disease, etc. And few words about urinary tract infections in neonates. The prevalence of urinary tract infection is approximately 7 to 15% among neonates and young infants. And UTI is usually uncommon during the first 3 days and generally present in the second week of life. And again, incidence is higher in uncircumcised males. And with decreasing gestational age, the incidence or risk increases. And in neonates and also in young children, we have to exclude structural abnormalities when they come with a positive urine culture. So in neonates also the most common organism is E. coli. And in hospitalized neonates, especially preterm infants, other organisms like coagulase negative staph and Klebsiella can cause UTI. And signs and symptoms of neonatal UTI can range from like episodes of fever, failure to thrive, conjugated hypobilirubinemia, and vomiting, and even apnea and hypoxia. So in neonates, so we can take a urine sample with, as I mentioned, by catheterization or suprapubic aspiration, and bag samples are not recommended. And as you know, neonates are quite different to older children and adults. So we can't like wait for culture reports and to start them on antibiotics. So if we suspect sepsis in neonates, we have to start treatment and then wait for the cultures, right? Because as you know, their immune mechanisms are not strong like in older children, and if you don't treat them properly, they can deteriorate rapidly within hours and even die, right? And if there's any suspicion, you have to always with the urine culture, you have to, if you suspect sepsis, you have to take blood culture, and if it is relevant, you might have to do a lumbar puncture and CSF culture also. So we start treatment after taking these cultures, and later on, depending on the culture reports, we can change the antibiotics. So usually uncomplicated neonatal UTI we treat for 10 to 14 days, and other children, older children, we can initially start them on IV antibiotics, and with the clinical improvement we can change over to oral antibiotics. And we have to do a ultrasound scan to look for structural abnormalities. And when to do a MCUG. So if they have the ultrasound scan is abnormal, or if the UTI is caused by non-E. coli pathogen, if there's recurrent UTIs, then we have to do MCUG. And a bit about acute infectious cystitis. Again, we have to treat them with antibiotics which cover E. coli, and sometimes we can use our sensitivity pattern in our institution when treating these children, and usually we can use second and third generation cephalosporins, and also even first generation cephalosporins. In sexually active females, we have to use uh, antibiotic which will cover Staph prophyticus as well. For example, nitrofurantoin. And then So usually if you are treating with appropriate antibiotics, these children should improve within 1 to 2 days. But if they are not improving, then we have to do investigations, and we might have to change the antibiotics. So acute management, imaging, and prognosis. So most children with UTIs we can manage out on outpatient basis in our clinics, but there are some indications to hospitalization. So these include age of less than 2 months, if they are clinically very septic, like the child I discussed at the beginning, or immunocompromised patients, for example, maybe a child on immunosuppressive treatment or steroids, or any syndromic child with immune problems, and then vomiting or inability to tolerate oral medication, and lack of outpatient follow-up, and if the outpatient treatment failed, then we have to admit them. So you can take a urine culture, and then we can start them on empirical antibiotics. So we have to cover them with antibiotics which will cover the most common organism, that is E. coli, and we have to guide our antibiotic selection according to our local guidelines and the resistant pattern. And once we get the culture reports, we can fine tune our management. So we can use cephalosporins to treat them, and also if they are having high fever, we can use second generation or third generation oral antibiotics, and if they need IV antibiotics, we can again go for third generation cephalosporins and also aminoglycosides. So duration depends on the age of the child and also clinical scenario. If the child is having UTI, usually we have to treat them for 10 days. And afebrile children, usually we can treat 3 to 5 days. So in our practice, we treat them for 5 to 7 days. As I mentioned before, if you are using the correct antibiotics, they should show improvement within first 24 to 48 hours. So what will you do if the child is not improving with your initial management? Then you have to look for complications, right? For example, you have to do a ultrasound scan, KUB, to look for any renal abscess or any pus collection in the abdomen, maybe retroperitoneal collections, or again you have to exclude other surgically correctable anatomic abnormalities or obstruction. So obtaining MCUG, in what sort of children you do VUR, MCUG to exclude VUR. Children of any age with more than 2 febrile UTIs, and children with first febrile UTI with any renal anomalies detected in the ultrasound scan, and high temperature, and if the UTI is caused by any other organisms than E. coli, and if there's poor growth and other complications like hypertension. Investigations, planning the investigations again depends on various guidelines. So if you take NICE guidelines, so ultrasound scan, here you can see So if the child is less than 6 months, they recommend ultrasound scan. But if the child is more than 6 months, you do a scan only if it's a atypical or recurrent UTI. But in our setting, as I mentioned before, we have to do ultrasound for any child at any age with the first episode of UTI. And these guidelines varies, like I have listed there. You can see the nice guideline, American Academy of Pediatrics guideline, Italian guidelines, and Australian and Indian. So our practices like maybe different. In UK, when we were in doing the foreign training, so they have in our trust, like in UK, they have trust like collection of hospitals, like for example 3 hospitals taken together to make a trust. So in that particular trust, they have separate guideline which may be different to a nice guideline. So the factors like so if it's a young child, especially less than 1 year, and if it's a male, then we tend to investigate more such children. So yeah, so it's very important to educate these mothers, like always, even simple viral fever, you have to talk to the parents nicely and tell what is wrong. Like even simple viral infection, you have to tell the mother in simple words, explain to the mother what is wrong with their child and what we are doing. So how do you treat the bowel and bladder dysfunction? You can use time voiding or double voiding, and sometimes you can use laxatives if there's constipation, and if it's relevant, you can refer them to a subspecialist like a pediatric or urologist or gastroenterologist. So some time back we used to do a culture after treating the child for a UTI, but nowadays it is not routinely recommended, right? You don't have to do a post-treatment culture. And if they have recurrent UTIs, you have to start them on prophylaxis. And also, if there's a severe initial episode, and if there's additional risk factors, for example, bladder and bowel dysfunction, again, you have to start them on prophylaxis. So commonly used prophylactic drugs include nitrofurantoin and cephalexin. So usually, so some time back we used to continue these prophylactic antibiotics for months and months, sometimes up to 4 to 5 years. But now they recommend you should continue them only for 6 months, and during this time you have to observe. If there's no infection, then you can stop it. But if there are recurrent infections, then you have to restart. So that concludes my presentation. In summary, typical UTI needs minimal imaging without long-term follow-up. The current emphasis is on rapid institution of treatment and not on extensive investigation. Atypical and recurrent UTI need MCUG, DMSA with or without prophylaxis. And neonates may need blood culture, CSF culture if they are ill and having high fever. And children with renal scars and urinary tract abnormalities need long-term follow-up and investigations.